Hello and welcome everyone to all our viewers joined us. My name is Simran Chaudhary from Voice of Healthcare and it is my pleasure to welcome you all to another insightful session of our patient awareness initiative, Navigating Migraine with Experts, Not Assumptions. So today's discussion is themed around Beyond the Pain, a new vision for migraine care. When we talk about migraine, we know migraine is far more than an occasional headache. It is a complex neurological disorder that affects millions of people, impacting their physical health, emotional well being, work productivity, family life, and overall quality of life. Yet, despite its prevalence, migraine continues to be misunderstood, underdiagnosed, and often untreated. Many people continue to normalize recurring headaches, rely on self medication, or delay seeking specialist care because they are unaware that effective diagnosis and treatment options exist today. And through this expert led discussion, our goal is to move beyond assumptions and bring evidence based insights directly from some of India's leading neurologists who will explore the latest advances in migraine science, discuss innovation in treatment, and address the persistent misconceptions. And also help us understand and to examine how healthcare system can better support patients living with migraine. This awareness initiative is brought to you by Voice of Healthcare and powered by Amneal Healthcare. We sincerely thank all our supporting partners for this important public health initiative. Now it is my privilege to introduce our distinguished panel of experts. I would like to welcome Dr. Sreekanta Swamy, Director of Neurology at Fortis Hospital, Bengaluru. Thank you so much, sir, and thank you for joining. Thank you, sir. Our next speaker is Dr. Tapas Kumar Banerjee, Clinical Director and Senior Consultant Neurology at Peerless Hospital and Research Center, Kolkata. Welcome, sir, and thank you so much for joining.
Thank you. My pleasure.
Thank you, sir. Our next speaker is Professor Dr. Sudhir Kumar, Senior Consultant Neurologist at the Institute of Neurosciences, Apollo Hospitals, Hyderabad. Thank you so much, sir, for joining and welcome to our show.
Thank you.
Thank you, sir. I would like to welcome Dr. Vibhor Pardasani, Consultant Neurologist at Bombay Hospital Institute of Medical Sciences, Mumbai. Thank you so much for joining, sir.
Thank you. Thank you.
Thank you, sir. Dr. Kadam Nagpal, Director Neurology at Salubritas Medicenter and Senior Consultant Neurologist at Fortis Vasant Kujan Holy Family Hospital. Thank you so much for joining, sir. Thank you, sir. I would like to thank and welcome all my speakers present here. And to begin our discussion, I would like to start about, firstly to understand why migraine deserves much greater attention that it often receives. My first question is Dr. Sreekanta. So, migraine is often perceived as just a headache. So, from your clinical experience, how does it truly affect an individual's quality of life, productivity, and overall well being?
Thank you. Thank you for the question. And here is my answer. The migraine is one of the type of primary headaches. Primary headache means there is no definitive etiology that is known. This belongs to that category of headache. There are different types of headache basically. And the number one headache is a tension type, and migraine is the second in order. But it is more stress because it is more debilitating rather than the tension type of headache. Almost about 15% of the global population suffers from migraine, and this is not all headaches are not migraine, but migraine is one of the type of headache, so the reverse is not true. And migraine is given importance for one reason: it is not simply the pain or head pain, it has got many other things along with it. That is why it is no more called as only a simple headache or a bad headache. It is a complex of a neurovascular problem in the brain. That is why it has to be given a lot of importance, and because of its so-called economical, personal, and social burden it gives rise to, because it affects almost all the domains of a person who is affected with the migraine. Basically, To give some examples, cognitive domain patient who suffers from migraine may complain of difficulty to concentrate, difficulty to remember, and difficulty word finding. So any part of the cognitive domain can be affected, and it also results in family disruption, meaning you may not be able to attend his family function because of the migraine headache, and he may anticipate that the headache might come, so he may miss the opportunities in the office wherein he may be having a good opportunity to progress further, and his work efficiency comes down to almost about 30% if he goes to work with the migraine headache, or frequent absenteeism may miss him having good promotions or opportunities. That is how it affects every part of the life of a person who suffers from, including personal to professional to social life. All the domains of a life of a person who suffers from migraine will be affected. That is the reason why we need to give a lot of importance to
back part of the head, or I'm suffering from sinusitis if the headache is in the front part of the head. And with this kind of misconception, they see somebody who gives traction to the head because it's a spondylosis, or put a collar on. And some people, because of the sinus problem they think of, they go to the ENT specialist. And let me tell you once and for all that cervical spondylosis or chronic sinusitis is never a cause of headache. Almost all of these patients who suffer from recurrent significant headache are suffering from migraine. So this is a very common misconception that people have. Another thing I've noticed, that people say, oh, I probably have high blood pressure when I get headache. It's not that. When they get head pain, might be the pressure may go up, but they're not suffering from high blood pressure. If you take the pressure other times, you will find they have a normal pressure. So these are the misconceptions that delay the diagnosis of migraine and delay the treatment that should be given in migraine.
Thank you, sir. Thank you so much for sharing your views on this. In terms of misconception and myths, there's so much of myths around it, and you have cleared the air about this. So, as we're talking about misconception, and this often translates into delayed diagnosis and delayed treatment. Dr. Sudhir, although migraine affects millions of people in India, many individuals remain undiagnosed or inadequately treated. What factors are contributing to this significant care gap in terms of your experience?
Yeah, thank you for this question. And another important question. So if we can classify it into two factors. One is from the patient's point of view, and second is from the healthcare, that is doctor's point of view. So patient's point of view, many times patients they resign to their fate because they have been told by their friends or family members that migraine cannot be treated. So then after consulting one or two local doctors, they stop seeking better healthcare. So that is why they suffer for many years. And then when the patients come to us, when we tell them that it could have been treated earlier also, so that is one of the factors we see from the patient's point of view. Second is the access. So we know that migraine is common. You just now mentioned that the prevalence is very high in India, like other parts of the world, and the number of doctors who are specialized in migraine, basically us neurologists, the numbers are highly inadequate. So for if a person wants to consult a neurologist, it's not easy, and especially in the tier 2 tier 3, I know that we have further questions on that aspect also. So when a patient wants to consult a doctor who's expert in neurology or who has knowledge about migraine, then they are not able to access. So I think I would look at these two factors which result in delay.
Definitely, sir. I agree on this point, and I think that's what causes the most delay when we talk about that why a patient has not reached a doctor on time, and why this has spread, or it has prolonged this much. So I think a very valid point stressed upon. My next question is Dr. Vibhor. So early diagnosis has potential to significantly improve patient outcomes, and that's what we are trying to create awareness around. So beyond recurrent headaches, what early clinical signs or patient characteristics should healthcare professionals and primary care physicians recognize to enable earlier diagnosis and reach to the doctor on time?
Okay, thank you. So, see, as has already been discussed, that among the primary headaches, tension type headache is the most common and is followed by migraine. So, it is very common to confuse the two. So, when we have episodic headaches which are occurring every few days and not daily headaches, and they are very severe enough to disrupt everyday life, causing absenteeism from work, loss of income for housewives, loss of work at home. So, when it is a severe headache, it is occurring in an episodic manner that alerts us that we might be dealing with migraine rather than a tension type headache. And then there are other criteria which helps us in making a diagnosis, which include things like hemicranial headache, associated nausea, vomiting, aversion to light and sound. So
Yes.
these characteristics also help us in diagnosing. These are the characteristics which help us in diagnosing that it is a migraine and not any other type of a headache.
Thank you, sir. Thank you so much for this response. And
So,
I
so regarding, yeah, regarding the investigations, there is no single biomarker or a single imaging characteristic or any investigation which can diagnose it. So it is mainly clinical. But very commonly we see that patients with migraine have non-specific white matter abnormalities in the MRI. So some non-specific problems in the MRI. But remember, they are non-specific. They are not diagnostic of migraine. So the main diagnosis is by clinical history and not by any other biomarker or investigation.
Thank you, sir. Thank you so much. And I think, like you said, that when people reach to doctors late and because they are not able to understand or diagnose the symptoms early, I think that's what creates the barrier. And as you said, I would just build on that. To Dr. Kadam, sir, many patients spend years managing symptoms on their own before reaching to a neurologist. So after relying on self medication and before consulting a specialist, what are the key behavioral and healthcare related barriers responsible for these delays? So you're on mute, sir. We cannot hear you, sir. No, sir. So you can leave and rejoin. I think that would help.
Yeah.
Yeah. I would like to, take my next question as we will have Dr. Kadam once again after this. So now focusing on the evolving science in migraine, innovation and diagnosis and treatment. My question is Dr. Sreekanta. Sir, over the last decade, migraine research has witnessed remarkable progress. So to our understanding of migraine has evolved remarkably over the past decade. Which scientific breakthroughs have had the greatest impact on current migraine management? If you could explain us on that.
Thank you for that nice and important question, which would highlight many of the milestones in the understanding of migraine. We go back to 1920s, wherein ergotamine was started to be used in migraine. Before that, there were no specific medications. Some gels and the ointments were applied, but the specific medication which started to be used in migraine was as early as 1926. Subsequently, the 60s, 1960s and 70s saw some of the medications which were related to like beta blockers and anti-epileptic drugs which were incidentally found to help migraine patients when they were used for some other reasons. Till that time, we did not have a migraine specific medication. The milestone after around 1980 started when the neurovascular theory was put in strongly, and that is when the triptans came into picture, which were even now they hold a very good place in management of acute migraine pains. And of course, after the triptan in 2010, that is another milestone wherein the Botox injection, botulinum toxin injection came into migraine management line. And it was also incidentally noted that people who were receiving Botox injection to the, face and other cosmetic purposes, they also found that their migraine frequency became less. So that is how incidentally it was noted. And subsequently, botulinum toxin has been very much approved by FDA, and it is used now for the chronic migraine. And among all these things, the most important milestone, which I think we should call it as a big breakthrough in migraine management, is the advent of CGRP antagonist drugs. That was in 2018, where first drug was approved for usage of migraine, because this is the only medication which acts specifically on a migraine related neuropeptides. Compared to the previous medications, they were used for some other purpose, but incidentally noted to help migraine. But here, this specific molecule, that is CGRP antagonist, are specific to calcium gene related peptide blockage, which prevents the migraine. And a lot of happenings have been going on from 2018 till now. Every year, or and sometimes within a year, one or two new molecules are coming up, both in terms of injectables as well as in terms of tablets for both acute and chronic. So the subsequent things, these are the important milestones which we have to remember when we talk about the management of migraine. Especially so, the CGRP antagonist, which came into market in 2018 and approved for the further use. And people have been very much happy with usage of this medication with a lesser side effect compared to other available preventive medications.
Thank you, sir. Thank you so much for shedding light on what all medicine and what all treatment options which are available to us. I would go back to Dr. Kadam for my question. So, can you hear us?
Yeah, am I audible now?
Yes, sir. You are audible now. So, to my question, my question to you is: many patients spend years relying on self-medication before consulting a specialist. So, what are the key behavioral and healthcare-related barriers responsible for these delays?
So predominantly, what we understand is the persistent supply of over-the-counter medications as far as painkillers to the patient is being concerned. It's very high, right? So these are the patients who often just like land up on a chemist shop asking for random painkillers almost on a regular basis, right? So rather than going to a neurologist and just getting to ascertain what kind of headaches they are going through. So we understand that the patient's perspective is always there to just like find out a shortcut, but unfortunately, migraine, there is no shortcut process to it. I can recall my days in neurology residency where the first line of the treatment of migraine is that there is no particular cure for migraine. So first of all, we have to understand that there is nothing which is permanent or which would be like long lasting, although the treatment can be customized as per the patient's need. So the patient's needs have to be put up across the table, and then accordingly a treatment strategy has to be designated as per the patient profile from the healthcare side. So the shortcut approach has to be avoided from the patient perspective, and accordingly a treatment management has to be just designated by the healthcare professional so that the patient can adhere to it for a long term basis. Simultaneously, the follow ups are also very important. They could be, because as we understand, once the headache subside, the follow ups, the patient usually is lost to the follow up. After 6 months or 7 months down the line, she might just come up in the OPD for a repeat similar episodes, and thereafter the medicines have to be just restarted all together again. And we see that many a times different combinations have to be used simultaneously. So adherence to a strategy and follow-ups are very essential.
Maybe rightly pointed out, sir, adherence to the prescriptions and the continuous follow up is required. I think that's how a patient can be in touch with doctor, and a doctor can always review the history and the kind of changes which is happening, and can always recommend a better treatment plan. Moving on to my next question. My question is to Dr. Tapas. So one of the, as Dr. Sreekanta also mentioned about, the treatment options available. So one of the most exciting development which has been is the emergence of CGRP targeted therapies. So CGRP targeted therapies are redefining preventive migraine treatment. Which patients are likely to benefit the most, and how are these therapies changing the clinical practice also?
Right. Okay. If you think of the preventive medicines for treating migraine, we had these options of beta blockers, the anticonvulsants and other things. But CGRP antagonist stands to be the probably the most powerful preventative medicine at present. Now, if the migraine keeps on occurring, it reaches a stage when you call it a chronic migraine. That means more than 15 attacks are happening every month over subsequent 2 to 3 months when you say it's a chronic migraine. And there is a situation called high frequency migraine, where around 7 to 14 attacks of migraine plus headache occurs per month. So these high frequency and chronic migraines are those who should be chosen nowadays for CGRP and receptor antagonists, because they are supposed to be the most powerful agent to prevent migraine attacks, because they're specifically targeting the CGRP. It doesn't have any other adverse effect because it's not going to other kinds of actions. So those patients, particularly if they have a chronic migraine or high frequency migraine, and they have already tried out the various preventative measures, not really getting any result, very effective result with it, or they're having adverse effects with the other agents, they should be having this option of CGRP antagonist drugs.
Thank you, sir. Thank you so much for shedding light on this important topic, that how CGRP targeted therapies are helping in terms of the patient treatments in the clinical practice as well. As we move ahead, my question is Dr. Sudhir. So, as clinicians, we know that two migraine patients presents exactly alike. So, as migraine presents differently in every patient, how close are we to delivering the true personalized treatment based on disease patterns, triggers, and patient characteristics?
Yeah, it's a very important question, and as Dr. Tapas sir also mentioned that we have various treatment options, and that's good for us treating physicians and also good for the patients. So we can individualize treatment. So now, if you look at patient features, basically the migraine features. So some people can just have episodic migraine, like in a month, maybe once or twice they get headaches, or even lesser than that. So such patients we don't need to put them on preventive medications. We can give them SOS pain relief medications, and that generally takes care. And if they have more than 3 episodes of headache in a month, definitely they require preventive medications. And then also we need to recognize little odd patterns of migraines. So somebody who comes with classical headaches along with nausea, vomiting, photophonophobia, we have no problem in diagnosing. But sometimes patients come with just eye pain or pain behind the eye and nothing else, or some eye-related symptoms. It can be like visual aura, and so we need to recognize them. Earlier also our other speakers mentioned some people can just have severe neck pain and radiating to the head or from the head to the neck. So we need to recognize those patterns of migraines also, and then accordingly treat them. And then if triggers is the second point you asked, so definitely very important if we can spend some time discussing with the patient what are the triggers, and if they are able to avoid them. For example, it's strong smell, that is can trigger headaches in some people, so that is called osmophobia. If they can avoid that, again headaches can be reduced. Some people sleep deprivation, stress, delaying their meals can also be triggers. So if we are able to identify those triggers and patients can prevent them, the good number of headache episodes can be prevented. And finally, the patient features. With that, mainly we look at comorbid conditions. So someone who's already overweight or obese, we avoid certain drugs like fluorescein, sodium valproate, divalproate, because they can cause weight gain. Somebody who has sleep disturbance also, we take advantage of certain drugs like fluorescein and amitriptyline, which can help in sleep also. And someone who's having bipolar disorder, depression, and migraine, then certain drugs like divalprox, they are useful. So depending on patient's features, also we can choose the correct drug.
I think so. You explained it well that how, based on the different characteristics present in a patient, and how we can personalize the treatment based on this. So I think that really helps, the patients to get rid of the disease or the pain easily, or as when according to the characteristics present. My next question is to Dr. Vibhor. So, technology is becoming an increasingly valuable partner in neurological care. So, how are advances in neuroimaging, biomarkers, and digital health technologies are improving diagnostics accuracy and also helping clinicians monitor treatment outcomes more effectively?
Okay, so as I mentioned even earlier, and as all my co-speakers have also been emphasizing, the diagnosis of migraine is mainly clinical, and there is as yet no foolproof biomarker which can diagnose a patient uh, with migraine. But we sometimes use neuroimaging when the patient comes to us with a new onset headache, or when the patient has some atypical features of migraine. Then we try to do a MRI, a neuroimaging, to find out if there is any other cause of headache which is masquerading as headache. So, like what we call a secondary headache, some tumor, some infection, some inflammation. So, MRI is done basically for that. The other imaging techniques, the newer advanced imaging techniques, have sometimes helped us in the research purposes to know, for example, what is the connectivity between different tissues in migraine. Then the neurovascular theory that was mentioned earlier, that also sometimes has been demonstrated in research models, like that there is a wave of hypoperfusion which is passing the brain in classical migraine. But all those are research tools. For a day to day medical practice, neuroimaging is more for secondary headache rather than for migraine or to actively diagnose migraine. Uh, Other technologies, biomarkers, the calcium gene related peptide can be abnormal during an episode, but then nobody measures that. It is basically done only in cases of research. Then wearable technologies was also mentioned by you. So we can keep a headache log in the form of a smartwatch in which we can record when did the headache start, when did it subside, what were the associated symptoms. So at the end of a specified period of follow-up, when a patient comes to us with a very objective record of how the headache has been uh, from the last follow-up, that helps us a lot in optimizing treatment and in uh, personalizing treatment for that patient. So that is the role of these newer technologies in that. There is also an instrument called Merivio commercially, which is also an advancement which can sometimes cause improve acute episode of migraine, and it is said that when it is used chronically, it may also act as a preventative treatment. But the personal experiences with that is very limited, and it is usually used for refractory cases, which is a very small percentage of migraine patients. Most migraine patients would respond to some or the other form of medical therapy.
Thank you, sir. Thank you so much for giving us this clear answer on it. And uh, rightly mentioned that maintaining a logbook on what is triggering your migraine attack, what is triggering, and when it is triggering, how frequent it is, it will give a clear picture to the current condition. And I think that will really help clinicians as well to understand the patient, the complicated cases and what treatment options are available for them. So I think this is a very important step for our audience also who are listening, that in case they are witnessing a migraine episode, to do maintain a logbook kind of thing on mentioning about how it is happening, when it is happening. And yes, wearable devices are really also helping nowadays to have a track of all these things. Moving on to my next question, Dr. Kadam. So, effective migraine management extends well beyond medicine alone. So, beyond medication, which lifestyle modification and evidence based non pharmacological approaches have shown the greatest benefit in reducing migraine frequency and improving patient outcomes. If you could shed some light on this. So, you're not audible again. This ambient sound is there, but I cannot hear you. So you can rejoin. No, sir. So, yes, sir. As Dr. Kadam is rejoining, we do have a audience question. This is that once my migraine starts getting better with treatment, what common mistakes should I avoid to prevent them from coming back? Dr. Tapas, could you please help us take this question ahead?
Yeah. Thank you. I think one of the most important tip that I can give to the patient is that maintain a normal, healthy quality of life. Because I mean, there are certain provokers of migraine. One is some food items, like if you take too much of caffeine, like taking excess of coffee, chocolates. Um, these are the things that can trigger an attack of migraine. So avoid those, and you should avoid fasting. Sometimes fasting, prolonged fasting, may trigger headache. Exposure to sun can trigger headache, or sort of if you have the sleep-wake cycle not proper, that can trigger headache. Another thing, the most important thing in the modern age is the stress. The mental stress sometimes triggers headache. So avoid those stressors or sort of provoking factors. Once you have now become better in the migraine treatment, so you avoid those provoking factors and maintain a healthy quality of life. That should be the first thing that one has to be aware of.
Thank you, sir. Thank you so much for answering that question. Dr. Kadam is with us. So, can we just have a
Sorry
quick
for
audience check?
for the delay. Apologies for the same. So I
No
hope I'm
problems.
audible right now.
Yes, sir, you are audible.
Great, great. So, as we were discussing, that the approach of treatment for migraine is very holistic. So, we start from the non-pharmacological aspect of the treatment predominantly, where we sensitize and make the patient aware that the patient should be aware of the triggers. So, as Dr. Vibhor mentioned, that we often ask our patients to maintain a headache log or a headache diary. If they are able to just tabulate in their smartwatch or in their devices, or just maintain a handwritten one, so that they get to understand what the triggers are. Whenever the headaches happen, are they coinciding with the periods? Is there any kind of a coincidence with some kind of a meal which they had? Predominantly, that could be having some kind of a cheesy component to it, or a junk food component to it. They might be smoking, or just having red wine a day or a night prior to it, and then might have just like landed up with a similar sort of a headache. So we make the patients aware and sensitized that they have to tabulate their headaches. So, well, once they know their triggers, avoidance of the trigger is a mainstay of the treatment. So that is a non-pharmacological aspect of it. Alongside having a healthy lifestyle, avoidance of junk food, and avoidance of smoking, wine, alcohol. That's all that would really prevent an attack. But there are certain aspects which cannot be which certain triggers that cannot be avoided, like going out in the sunlight. So if somebody goes out in the sunlight and that turns out to be a trigger, we often ask the patient to just wear shades, or just go out with a hat or something like that. So we cannot avoid completely going out predominantly. So the triggers have to be known and the triggers have to be managed accordingly.
Very rightly mentioned. So I think the triggers have to be managed accordingly. And as we move ahead to my next round of questions, which is empowering patients, the next chapter in migraine care. So as we look ahead, the future of migraine care is not only about better treatment; it is also about empowering patients for actively participating in managing their condition. So my question to Dr. Sreekanta is, so healthcare today is increasingly focused on prevention and long-term outcomes. So how can healthcare systems shift their focus from managing migraine attacks to building a long-term preventive and patient-centered care strategies?
Well, I think this is the most important question to answer to the public, because they must be able to understand that treating an acute attack uh, makes them comfortable, but it is not the answer, because migraine, as we know, it's a chronic disease. It's not 1 day or 1 month or 1 year disease. It keeps coming and going for many years. So we need to look at what disability it produces, what professional or personal life changes it produces over time. So we need to look at prevention of this migraine, because acute attack to treat frequently might result in what is called analgesic induced headache, which of course also can turn into chronic migraine, which is extremely difficult to manage by any person who treats a migraine. So before we push the patient into that category, we need to look at how we can help him. We need to look at the patient as a whole. It's not the pain that we are treating, it is the migraines syndrome like thing which we are treating. How we disabled is, how he's losing his profession, his income, how economically becomes a burden to the society. We have to look into that aspect, and that is how we have to create a long-term plan to prevent getting more frequent headaches, which will lessen all these factors, to be honest with you. And in this term, we need to look at whether it is a lifestyle changes that can be corrected, whether it is a trigger factor that can be corrected, or any environmental factor. Supposing if somebody is working in a factory where there is a lot of noise, that could be one of the reasons for to get frequent headaches, and there's no point in giving him medication to treat him every day. We need to avoid that situation wherein he may feel better. So that is how every aspect of his lifetime disability has to be addressed into. And patients have to be taken into confidence when we decide about long-term management, because it is their right to accept what we offer to them, whether it is in terms of management with the long-term medication, whether it is low-cost medication or high-cost medication, especially those who are which are in the market now. CGRP antagonists are very high-cost medication which cannot be afforded by most of the people. So we need to discuss with them whether they want to take these medications or they want to be satisfied with the available low-cost medications itself. What is their monetary status, and whether they are reachable by the doctors to follow up them, or whether they can reach the doctors who can guide them properly. All these long-term plans have to be planned not only as a pain management, but as a migraine symptom management as a whole, so that patient can live a pain-free life and disability-free life in the future for a long time. And that makes him more comfortable to stick on to the medication also. Supposing he takes a medication which makes him better, after some time again he gets fed up, and finally he says, I don't want to take it because it keeps on coming. So when we plan for a preventive long-term measures, he might be able to accept the offering medical treatment, and he may look into the more brighter part of the life. That is how the future has to be planned, not only as a plan to treat the pain, but as a plan to prevent and make the patient more comfortable with the purview of the available preventive medications.
I agree, sir. I think it is a very good way when we inform the patient also, and then the patient also knows about what are the treatment plans available, how this is going to be treated, and I think that gains more trust between the clinician and the patient also, and when the faith is there, I think the treatment also goes in a better way. So, as we're talking about an informed patient is often an empowered patient. So, my question is, Dr. Tapas, sir, in your experience, how does patients' education influence treatment adherence, self management, and the reduction of stigmas associated with migraine?
Yeah, I mean, education always helps to make a healthy change in life. So if you make the patients more and educate the patients and make them aware of the fact that migraine is something, a very prevalent and common disease, they should approach a neurologist or a headache specialist if they have a recurrent significant headache. Second thing is that sometimes when you have the headache, we take a painkiller to get a relief. But painkiller is not the answer. We have to educate the patient about that. If you keep on taking painkiller, you might reach a stage when you call medication overuse headache, which can make the headache more chronic. So if the headache becomes frequent or migrainous attack is frequent, change your lifestyle, get into a healthy lifestyle, expose the provoking or the trigger factors, and get into a preventative management. Take the medicines which are preventing the attacks of migraine coming. There are the list of medicines what my co-panelists have already mentioned. And to remember, now we have a more powerful uh, preventative medicine available here. So these options are there. Take a course of preventative medicine for 4 to 6 months, and which can sort of arrest the headache for a long period of time, and maybe it will lead to a more persistent relief from migrainous headache. So these all, the advantage of this preventative medicine and taking them regularly can prevent migraine attacks and change their quality of life is something which should be emphasized to the patient, and that will definitely create them better awareness, and the adherence will be better.
I agree. So I think that will definitely create better awareness and there will be better adherence to it. So as we're just talking about, how it is beneficial when we take patients into account, and we're talking about the better, as time is evolving, how what all options do we have? My question is, Dr. Sudhir. So digital health tools are becoming more accessible than ever before in today's time. We have devices like wearable devices and any other technological advancements are also there to measure it. So, with wearable devices and digital health platforms becoming increasingly accessible, how can these technologies empower patients to better understand and manage their migraine patterns?
Yeah, it's a very important point because we need to know we need to gather a lot of information for us to treat patients properly. So digital technologies and these apps can help in two ways. One is to capture data about the migraine itself, because many times when the patients come to us, we want to know how in the previous few weeks or few months what is the headache frequency, how long the headache lasted, along with the other features. So it becomes very difficult for the patient to remember offhand. So if the patient can start entering into some kind of digital record and maintain a record, it's so easy. And I have seen patients bringing to the OPD. So just one glance at it, and we can make out in the last, from the last review after the change of medication, what is the headache frequency and the duration. And if we can see a clear cut, more than 50% reduction in the headache frequency, severity, and duration, then we know that our medicines are working. That's one part of it. The second part is triggers. Many times patients are not aware offhand if you ask them what triggers their headaches. So if they can just start entering their foods, what all they eat every day, and then so over a period of say few weeks, they could be able to spot that after having a certain food item, they got their headaches. So they may not be able to tell often, but after entering in the record, they can tell it. And the sleep, now we have devices that can track sleep duration, the quality, the different phases, and we know that sleep is closely linked to migraines also, especially the sleep deprivation. So a person may be on the bed, but if the sleep quality and duration is not adequate, so again we can point out based on the app, the sleep quality was not good, and that could have triggered their headaches. Other thing is exercise. So some people who come to us, we know that exercise is a double S sport. So those who don't exercise and those who over exercise, both can trigger migraine. So again, that can be entered. Many devices, apps, they measure the duration of strength training or duration of running space, and we have been able to help certain runners and those who are do regular workouts to cut down their running, duration and pace, and then they can manage their migraine. So there are many things, such things which are available now for us to help migraine patients.
Definitely, so I think there are many ways to measure it, and like you said, whether just having a glance of it, the digital healthcare report or the wearable devices report that can give a complete picture of patient history on what all episodes it has been occurred, and if they maintain a diary of what food triggers, when it triggers the most, I think that gives a very good picture of a patient's current condition to doctor. So, as we move ahead to Dr. Vibhor, sir, migraine frequently extends beyond physical symptoms and affects emotional well being too. So, it coexists with anxiety, depression, and sleep disorders. Why is a multidisciplinary approach, including mental health support, is essential for comprehensive migraine care?
Yeah, so see, there are two, three aspects of this. One is that migraine is not simply a headache. There are many other comorbidities also associated with it. Secondly, there are triggers of migraine as we have all been talking about, and anxiety and sleep deprivation, as we have discussed, are very important triggers of migraine. So, if we keep treating the symptom, which means we are keep treating the headaches, but we don't address the underlying causes or underlying comorbidities adequately, then it will always be an incomplete treatment. The patient will never become as better as he or she can be with a proper comprehensive approach. So a comprehensive approach doesn't just mean giving multiple medications. So anxiety need not always be treated with anti-anxiety medications. Similarly, sleep disorders may not always be treated by sedatives, tranquilizers. They can also be treated by proper sleeping habits, sleep hygiene measures. So if we look at the other aspects, and all headache clinics or people who run headache clinics always ask this question, that how is the sleep? Is there any underlying anxiety? How is the mood of the patient between headaches? And when we address all these aspects, that is the time when the triggers of migraine get taken care of and the headache episodes start subsiding.
Thank you, sir. Thank you so much for answering this question. Now we'll move on to my next question to Dr. Kadam. So, innovation continues to transform neurology at an unprecedented pace. So, looking ahead, which emerging innovation in diagnostics, therapeutics, or digital medicine do you believe will have the greatest impact on migraine care over the next 5 years?
Yeah, this is hope I'm audible this time.
Yes.
Yeah, thanks. So this is a question probably we should be having a wider discussion about, that what exactly in the digital world would be just transforming the migraine care. But as mentioned by the co-panelist, like evolution of these applications and the wearable devices, and the ease to tabulate the or just like maintaining some kind of a chronological process of how the headaches happened, what were the causes, what were the reasons or the triggers that were just co-associated with it. Probably that would just transform the care in terms of the preventive attacks. And as far as we are seeing in terms of treatment, the treatments are ever evolving, device coming into place. Although I don't have a very great experience on this Neredio device, but for any kind of a refractory or a chronic migraine patient, I do prefer botulinum toxin to a large extent. But yes, as we understand, CGRP, it's a lovely space to be in, right? So monoclonal antibodies like erinumab is there in the space. So we see a lot of medicines coming into place, and initially the formulary was very limited. From ergotamines, the treatment strategies have evolved very significantly. So that's a good space to be in.
Thank you, sir. Thank you so much for this answer. And as we move ahead, before that, I have a question from audience. I would just like to present that on screen. That with so many online tips and home remedies for migraine, how do I know which ones are actually backed by science? Dr. Shrikanta, if you could help us take this ahead.
Yes, I think majority of the talking which we did so far as per the trigger factors and the tips which we have given is they are all backed up by at least some of the studies and the scientific background. It's not that they are not without the scientific background, because we have seen patients who have very bad sleep pattern experiencing more frequent and more severe headaches, which of course may not be documented as an evidence by any other biomarkers, but it is known. Secondly, if somebody travels for a long distance, some people get it, and it is a well-known fact that people who eat a lot of cheese and refrigerated food or fermented food, they do get headache. But those who are intended to get the headache, who are prone to get headache, they experience this, but not those people who are not prone to get migraine. So it is most of the studies are they have studied across the population and they have noted many triggers which can do this. And if you avoid these triggers, definitely you experience less and less severe headache, less and less frequent headache. And sometimes if you maintain your lifestyle properly, you may get a very mild headache once in a month or once in 2 months, which may not require any medication. So all these things have been proved over time by large number of studies, and that is why these tips are offered to the patients.
Thank you, sir. Thank you so much for taking that audience question and answering to it. As we have come to another discussion round, which is advancing equitable migrant care through public health and policy. So, for this session, the conversation broadens and discuss about how healthcare system and policy can improve migrant care across the country. To my question is Dr. Sreekanta. So India's healthcare varies considerably across regions. So do you observe meaningful regional differences in migrant prevalence, triggers or across to specialty care across India? And what factors might explain these variations when we talk about specifically of our country?
In our country, there are not many prevalence studies that are available, but whatever that is available, it is almost the prevalence is almost constant from south to north. Because in Delhi, the study proved that it is about 25.6%, whereas in Karnataka and Bangalore, the large study proved that it's almost in and around 25% of prevalence. So I think that as far as the prevalence is concerned, it holds good, but as far as the triggers are concerned, it depends on where the person is living, because triggers could be humidity, it could be warm climate, it could be very cold climate, and the food pattern, the way the religious observations are made, like fasting, etc. There are communities where they do eat only one food, or they do fasting for a certain month, especially both in different religion they do this, and they experience more of headaches in these countries. So triggers can vary from region to region, because India is a vast country with multilinguistic and different cultured people staying around, and they observe accordingly. So the uh, incidents and trigger factors also become very different in these countries. Third thing is that the way the person lives. For example, if he is a laborer working in hearts, and that sun itself can be a trigger factor, and dehydration can be another trigger factor in that. Whereas in cities who are living, especially nowadays, you are aware that the software people are erratic in their sleep pattern, erratic in their eating time, and their workload is so much they are stressed out. Stress is one of the very important trigger factor in the cities where they work on the computer, whereas this may not be an important stress factor in a person who is in village. And third thing is, most importantly, most of the low economic villagers, they won't get into the specialist consultation, because it is so difficult for them to come to the city to visit a specialist. And our general practitioner, family physicians are also not much updated to diagnose migraine, I mean headache as a migraine. So we need to look at that aspect also. And if they go in the village to the general practitioner, he might treat them only with the painkillers, which over time and which may result in chronic migraine. So there are regionalistic differences, there are cultural differences as far as the trigger and migraine severity is concerned, and also there are natural things which can change. Like for example, those people who stay in a coastal area, they are exposed to frequent humid weather, which can increase the frequency of migraine. And those who are in the cold climate, they may feel a little better. And those who are always doing late night works, shift duties, they may experience more of migraine headache and severity. And these are the things which we need to address. So it is since it is a vast country, there is always a diversity in terms of frequency, in terms of trigger factors, and in terms of the treatment availability for all these people who suffer with migraine.
Thank you, Stan. I think you explained it very well that how it varies region wise, and if it is not, then what? If it is, then what are the factors to it? As we move ahead, my question is Dr. Tapas. So we know that changing lifestyles are reshaping the disease patterns across all age groups, like Dr. Sreekanta also mentioned about it. So how is urbanization changing lifestyles and environmental factors where workplace stress and contributing to this growing burden of migraine across different population?
Yeah, in urban life, what you are getting sleep deprivation, lots of stress. Eating habit is poor because you are having a lot of coffee going on in the workplace, and the exposure to sun may happen. So all these factors taken together, the fast life is one thing which is a very important, and the stress is a very important trigger factor for migraine, which we get in abundance in modern fast life. In urbanization, definitely is increasing the prevalence of migraine as we naturally expect.
Thank you, sir. And I think I agree to this point where where the workplace pressure is there, the stress is there, and how the urbanization is there, it is little more prevalent as compared to the other conditions. Moving to my next question, Dr. Sudhir. So while science has progressed significantly, so access to quality care remains uneven. So despite advances in migraine treatment, what healthcare delivery gaps still continues to limit equitable access to quality care in tier 2 and tier 3 and rural India, to be very specific?
Yes, that's an important point. So when we look at the neurologists, overall, the number of neurologists for a huge country like ours is still less. So per thousand population or whatever per 10,000, we have less number of neurologists compared to other developing or developed countries. So that is why if a patient wants to access, and most of the neurologists who are available also, they are mostly in the bigger cities, definitely not in the rural areas. So if a patient with migraine wants to consult a neurologist physically, it is difficult. They need to travel to the nearest bigger town to meet the neurologist. But I think whenever we have a problem, we always come with a solution. And luckily in our country, the digital or the internet penetration is very high, and most doctors and many hospitals are offering online consultations. So, and migraine, as we have already discussed, it doesn't require expensive investigations or biomarkers or invasive testings. So based on the history, we are able to diagnose in most people, and treatments also can be advised online. So it's not a replacement for physical consultation, but because we have an issue of lack of healthcare professionals or good hospitals in the rural countries, at least for migraine we can promote where whoever cannot access direct neurologist, this online platforms can be used.
Right, so I think online platforms can be used where a few things are not available. So, to take my next question, Dr. Vibhor, so migraine has a substantial impact not only on health but also on the productivity and the economy. So, considering its significant impact on quality of life productivity, should migraine receive greater priority within India's public health and non communicable disease agenda also? And if yes, then why? We cannot hear you, sir. You're on mute.
Can you repeat the question?
Yes, sir.
Can you repeat the
I'll
question?
repeat the question. So, considering its significant impact on quality of life and productivity, should migraine receive greater priority within India's public health and non-communicable disease agenda? And if yes, then why?
Yeah. So see, the answer actually lies within the question, because uh, being a developing country, and since we had so many different challenges of managing infectious diseases, and then in the modern era we have a lot of oncological burden, which are life-threatening conditions. So a lot of public health programs have been focused on infectious diseases, communicable diseases, which are life-threatening. But at the same time, we should understand that there are two Indias. One India which lives in its cities, which have reached at quite a peak of development, and it's at par with the developed countries, and the problems there are different. So, migraine or any other medical condition which might be non-life threatening and yet be disabling and impacting the productivity of a productive young population should also be addressed by the public health system. And it is something which doesn't require too much investments either, because no complicated investigations are required, no complicated treatments are required. The key thing is identification and then availability of drugs. And we have been discussing that the newer agents, which are much more specific, are more expensive. So availability of that. So definitely it should be addressed as a public health problem.
Thank you, sir. Thank you so much for this, for addressing this. My question is to Dr. Kadam. So, as we have come to conclusion of today's discussion, so if you could recommend one policy or healthcare initiative to improve migraine awareness for early diagnosis and access to specialized care in India, what would that be?
As far as migraine treatment is being concerned, I would just suggest that although it could be a very radical policy, but this restriction of the over-the-counter painkillers to a large extent, because what's happening that we are seeing that the patient is popping in pill way too early and way too soon. So because of which we see that the episodic migraines get transformed to a chronic painkillers result in a medication overuse migraine. So medication overuse migraine is all the more a very complicated sort of an entity to just treat, because we require some kind of a drug-free period for to a large extent for the patient to just get acclimatized and accustomed to the treatment. So restricting the painkiller usage and making the patients self-aware about the clinical condition to a large extent. So as we understand, it's very easy for the urban population to comprehend what migraine is, but the rural people won't be understanding it to a large extent. And as speakers mentioned, that it should be a public health initiative, that the awareness has to be there, because technically the paraphernalia in terms of investigation are completely non-existent. You just need to know it well. You need to understand whether you're following or fitting the criteria of having a migraine-like episode, and then you have to just be on a treatment from a neurologist so that you can adhere to it for a longer period of time to be completely health free and productive in your workplace.
Very rightly mentioned, sir, and thank you so much for stressing on this and highlighting this important aspect. So, with this, we have come to end of today's discussion, and for this, I would like to sincerely thank each one of our distinguished panelists present here for sharing your expertise and valuable perspective and taking out time out of your busy schedule for this awareness session. So, as we are here for today's conversation, has highlighted an important message that migraine is a serious neurological disorder that deserves timely recognition, evidence-based treatment, and greater public awareness. So, by moving beyond assumptions and encouraging informed conversation, we can help patients seek the right care at the right point of time. On behalf of Voice of Healthcare, I extend my gratitude to all our experts have joined us, and to Amneal Healthcare also for powering this patient awareness initiative. Thank you for everyone. This means a lot to us that you have come together for on this platform for this great cause. Thank you so much.
Thank you.
Thank you.
Thank you very much.
Thank you
Thank you.
very
Thank
much.
you, sir.